right, let's get started. It's my pleasure to introduce today's speakers. The first speaker, Dr. Barbara Wilke. She's an assistant professor of anesthesiology, and she earned her medical degree from the University of Florida, and then did her anesthesia residency training within our department, which was followed by a fellowship in cardiothoracic anesthesiology. And in 2013, she then joined our faculty. And in 2017, she became the director of the Cardiac and Vascular Center, and also the fellowship director of the perioperative management of liver transplantations. She's a very dedicated teacher, got several teaching awards, very interested in quality improvement, and also is a Alpha Omega Alpha member. And then our second speaker, Dr. Eric Leindecker. He's currently a cardiothoracic fellow within our department, and he earned his medical degree from the University of Wisconsin, where he also did his anesthesia residency training and a critical care fellowship. And I heard he's more than ready to be done. All right, and today they were presenting two very interesting cases. Looking forward to it. Thanks a lot.
All right, good morning, everybody. Anybody hear me? Sound okay? Awesome. All right, so the first case we'll be talking about, I have it labeled as a little bit of an airway misadventure. I'm too loud. Sorry. Okay. All right, better? Yeah. Less reverb. So this was a case I was not involved in, so unfortunately I won't be able to answer a whole lot of direct questions about the care that happened. And admittedly, I would say that the airway management in this case is probably one of the lesser interesting aspects of this case to me. I think we've all that have been doing this for a little while have all been in a position where we've run into a difficult airway, and we've all had failed airways and things like this. But that kind of brings up a couple of the learning points, or learning objective that I have for this. The first one is really to be able to recognize that there's external non-anesthesia related pressures that are placed upon us in these kind of somewhat emergent settings, and how those may impact patient care. I think these are especially important for the trainees in the room. And also being able to acknowledge the importance of accurate documentation and be aware of the ramifications of inaccurate or incomplete documentation. This certainly is an ongoing issue and will be for the remainder of our career, that we remain liable for this kind of living, breathing legal document that we enter into every day. So getting into the case, so she's a 70-year-old woman. She had a history of rheumatoid arthritis and CVA. She was initially admitted to the cardiology service for heart failure workup in consideration of an LVAD placement. She came from an outside hospital in cardiogenic shock, started on dobutamine and with diuresis, and then transferred here on the 16th of February. Echo here, as expected, somewhat showed a poor LVEF, some severe TR, and then an apical thrombus, certainly indicating a low flow state. Right heart cath, fairly unremarkable given this setting, poor index, elevated wedge pressure, kind of as expected. She was transitioned to milrinone due to non-sustained VTAC. Diuresis was continued, though the VTAC recurred. However, with the lowering of the milrinone dose, there was now evidence of malperfusion. So on the 20th, the patient appeared to be decompensating. She remained on milrinone, though now hypotensive, requiring vasopressors. Despite diuresis and inotropes, lactic acidosis sets in. Her mixed venous drops dramatically, down to 38%. CT surgery is consulted for ECMO consideration as essentially a bridge to the decision. At the same time, kind of in the background, there's ongoing discussions about whether or not she's a candidate for a durable LVAD. Excuse me. So the anesthesia pre-op looks, pretty boilerplate, right? Like most of the anesthesia pre-ops look. What I want to draw your attention to are the airway details, though. Really nothing worrisome in there. Full neck extension, good mouth opening, Mallampati 3 for what that's worth, but good thyromental distance. So they labeled this an ASA 5E, given the imminent threat to life. So the anesthesia encounter, she came to the OR on milrinone, phenylephrine, lidocaine, and furosemide at the listed dosages. The sequence of events that I discerned from the chart review kind of are as follows. 1642, she was induced with etomidate, fentanyl, ketamine. In 1644, there's a quick note that we'll get to in a moment. And then the next note isn't until 1700 when epinephrine is started, and then 1729 when rocuronium is given, and then ready for positioning and prep at 1732, incision at 46, and then cannulation shortly after that. She left the operating room on VA ECMO, on epinephrine. The fentanyl was off, and milrinone was continued. The quick note kind of describes, in a general way, I guess, what had happened. And so, you can all read it. Essentially, it's a patient with an immobile neck, poor view, multiple DL attempts and VL attempts, and then mention of a needle cricothyrotomy prior to an open cric by CT surgery, and then pulse oxygenator of 58%. So as far as outcome goes, like I mentioned in the background, she's being worked up for a durable LVAD. They, after all of this, decided she was not a candidate for a durable LVAD, and family decided to pursue comfort measure, I believe, the next day after being put on ECMO. And so she passed that day. So questions I had when looking at this case, one, how do we account for the disconnect between the pre-anesthetic airway exam and what was reported in the chart? The pre-anesthetic airway exam, with the exception of the Mallampati score, really had no mention of poor neck extension, poor mouth opening, or anything really that would give me a whole lot of pause as far as, should this be somebody that should be cannulated awake? Should this be somebody that should have a fiber optic intubation done? Should this be an awake intubation? Or things like that. And my thoughts about that was, well, one, was this erroneous documentation, or was an airway exam even performed? In talking to people involved in the case, my kind of assumption is that this is a case of somebody being told, okay, we have to go emergently, we have to go, okay, let's just click through the buttons, get the airway exam done, not really doing an airway exam, but just clicking the buttons, and then showing up in the OR and finding that, okay, this is a dramatically different airway than was documented in the pre-op note. Was the ASA difficult airway algorithm followed? As documented, no. It reports a deviation to the jump from can't intubate directly to surgical airway with no mention of difficult bag mask ventilation, LMA placement, or things like this. And then lastly, what factors lead to this type of situation? Like I mentioned, the airway management alone isn't especially interesting to me. Did I get turned off? Can you guys still hear me? Yeah, okay. Isn't especially interesting to me. But what is a little more interesting is, like I said, a disconnect between the airway exam and what was found in the OR, and then, the issues with documentation. I think that external pressure, that, we have to go now mentality, especially as a trainee, can be very difficult to deal with. You're dealing with, fairly type A cardiac surgery attendings, fellows, things like this, that are telling you, we need this patient in the OR absolutely right now. We have to go. Just pack the patient up. You have to go. And, it can put you in a difficult position to then say, no, we need to stop. We need to do a thorough history, a thorough physical, exam, gain actual consent from the family, and things like this. But it's vitally important that we do that. The other issue is the in-room provider not performing the personal pre-op. It seems like the practice here seems to be that residents will run around and do pre-ops, for instance, for cases that they're not doing. And that seemed to be the case here, where the person that did the pre-op may be transported but was not the in-room provider. And certainly there's information that can be lost. For instance, like I mentioned before, was an airway exam even performed? And if it was, was the documentation erroneous? And, was the airway exam actually communicated to the in-room providers? So that's all that I have. Those are the questions that I had for this case. Yeah. Yeah, absolutely. Sorry, one second. Got to get through all my animations. Yeah.
Somebody must have
Isn't it? Okay. Yeah.
Somebody has done it, right? And things can just not be assessed always. How many times we get told we do an exam and then we look down the road? It's very difficult or the other way around.
Yeah, I think, what really stood out to me. What really stood out to me about that, though, is that mention of the neck being normal, the full range of motion, and then in the quick note, the issue being the neck's immobile. So, I mean, there's still, even given that, even if somebody did an airway exam, there's still a big disconnect between what's documented in the pre-op and what was seen in the OR.
I did hear your point about not doing your pre-op elevation important one, especially in a case like this, because even if this was a perfectly documented airway exam, the person doing the case has to either look at it, read it, or talk to the person that actually examines the patient prior to that patient going to the OR. You talk about external pressure. Well, the external pressure really starts when you get to the operating room. They sat on this patient with PAC and evaluated their performance.
Oh, I agree. I agree. Yeah. 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 No, I agree. Yeah, those external pressures. I would disagree a little bit that I don't think it starts when we hit the OR. I mean, I think like Dr. Wilkie mentioned. I mean, I think it starts up on the floor when you're being told to really expedite care or expedite transfer at the potentially at the expense of care.
So there's any evidence showing what is the correlation between our exam and the difficulties with intubate? Do we have any studies that look at that? Because I find it actually to be often, except for the next motion, often to be fairly worthless.
I agree.
When I say Mount 94, that's a little bit of A1Q and got fuel many times. So is there a particular study to show what's the correlation?
I know there have been in the past, and I think the one that was most predictive was the excursion of the incisor, so able to bite your upper lip. I think everything else, I think you got to take into kind of this milieu of an airway exam, and certainly, that by itself can be an independent predictor of difficulty. But I think the others, as you add them in, can increase the kind of validity of an airway exam, but it's still not very high. It's still not really, I wouldn't consider it a really valid exam.
Yeah, what's the predictive value?
I think it's low. It's very low. Yeah. Dr. Saris? Yeah, I agree. Yeah, I agree. I think it's just kind of become one of those things that we do now.
So I think upstairs, you can do a thorough exam and go right in and do the shot one way or the other. Pleasant surprise.
Oh yeah, I mean we've all had unrecognized difficult airways. I don't, like I said, I don't. I think that's the less interesting aspect of this case. But.
Are you putting together an airway, like an after hours airway, or is that something that they could easily get airway equipment after hours? Yes.
You're talking about LV venting? Yeah. I agree.
And also, Joe, underscore to the community that you're gonna run into these situations where everybody else has had time to do their doctor assessment and planning and consenting, and then all of a sudden, you know, it's hair on fire, waiting to rushing down to the OR, like our stuff doesn't really matter. So it's important to take a quick snapshot of the situation and see, you know, where on the emergency scale is that, right? And do I have time to do the normal things I would choose to take somebody to the OR? You don't have to do a whole history, physical, review system, blah, 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 but like find some system that you're quick and dirty, what I need to do, and unless they are clearly about the code, don't let people bully you into not doing what you need to do to take care of the patient safely. Because you know this, like, for most of these situations, when you're in the operating room, the surgeon runs into a problem and they consult another surgeon. That person that comes in to help them doesn't come in guns a-blazing and, you know, not doing their assessment and their normal stuff. They still go through their normal processes just in a consolidated manner. So develop consolidated manner to do this. And unless taking that 3-4 minutes to find information that you need is going to result in that scenario, hold your ground and say, no, I need to do this. Because if I put this patient to sleep and I can't put the patient and I haven't done an airway exam, then, you know, everybody else who's standing here to help this person now has nothing to do, right? So we are important and we have to sometimes remind people of that.
Any other questions at all?
All right, is it on? Ooh, yeah, okay. So this was a case, a 79-year-old man with hypertension, diabetes, previous AAA repair, like in the years past, TIA, current smoker, who presented with an STEMI. He presented for CABG 2 days after his NSTEMI, and he had been maintained on IV heparin, integralin, and aspirin prior to his CABG. His platelet count the day of arrival to UC Health was 162, and then mid-140s, and then the morning of surgery, it was 113,000. He had an uneventful induction for his CABG. His ACT was maintained over 480 during bypass, and that's our goal. This was one small exception. The last ACT before coming off bypass for the final time was 466, and that was at 12:14. And he came off a bypass and stayed off a bypass at 12:20, so very little time there. He did have a little difficulty separating from bypass initially due to some RV dysfunction, so they went back on bypass, changed their medical therapy, and then he was able to come off bypass without incident. The operating room course was otherwise pretty unremarkable for this type of surgery, except that at 11:18, he was found to have a platelet count of 31,000. So it's a very significant drop from his platelet count earlier in the morning. They did repeat it and found that it was correct. The repeat was 27,000. So it's kind of a very scary thing to have a platelet count that low and be coming off of bypass. So even though he was not bleeding at the time, they went ahead and replaced his platelets with 2 units of platelets. Otherwise, he received no blood products, and he was reversed and taken to the ICU. He was on a little bit of dobutamine, a little bit of epi, and a little bit of vasopressin, and inhaled Bleetry. So after he got to the CTICU, he became hypertensive, very significantly hypertensive, which is something that we really worry about when somebody's been putting sutures in the thoracic aorta. So he wasn't on much that was going to raise his blood pressure, just a little bit of vasopressin and a whiff of epi, but that was turned off. And soon after, he got very hypotensive. And then he did not respond to large doses of inotropes and vasopressors and had a cardiac arrest. So his chest was open in the ICU. They did internal cardiac massage, which is suboptimal in somebody who has bypass grafts. They peripherally cannulated for ECMO. The femoral arterial approach was initially left, but this failed, and then they successfully cannulated his right femoral artery, and then we took him to the operating room to explore things some more. So when we got to the operating room, the question was, what caused this arrest? Was it ischemia from hypotension? Was it a surgical problem with the grafts, which they felt was probably not the case because they had Dopplered the grafts prior to closing the chest and taking him to the ICU, and they had good flow? Was this a clotting event, or was it some other type of problem? So one thing they noticed in the OR initially was that he had no pulses in the left leg. That was the first site for arterial cannulation for ECMO. And then they ultrasounded his grafts with the Medistim probe and found that 3 of his 4 bypass grafts had significantly diminished flow. He had become thrombocytopenic during the bypass run, in which he was on a large amount of heparin. He was started on heparin after he was peripherally cannulated. So we made the decision to treat him like he had hit, and this was a hit event. And we took him off his heparin, and we started bivalirudin. Also part of our standard of care for cases that involve cardiopulmonary bypass is an antifibrinolytic, which he was still on, so we decided to discontinue the antifibrinolytic as well. And we took him to OR7 for angiography of his grafts. Angiography of the grafts revealed that 3 of the 4 were thrombosed. And decision was made to stent his native vessels instead of try to redo his bypass grafts. So the dose of bivalrudin for percutaneous coronary intervention is literally a magnitude greater than what we use for ECMO in the ICU. So an order of magnitude greater. Then we also had to give him cangrelor, which is a platelet inhibitor. It's a P2Y12 platelet inhibitor that's a quick on, quick off. And so with the addition or the increase in the bivalrudin and the addition of the cangrelor, we really started bleeding. Prior to this point, we had only transfused 4 units of red cells, and we hadn't given any plasma and obviously no platelets. So with the increase in his anticoagulation for the percutaneous coronary interventions, we developed a very, very significant coagulopathy, went on the massive transfusion protocol and then the catastrophic transfusion protocol. And then we had this discussion with cardiology, because we're bleeding a lot, and cardiology said, please don't give any FFP because we don't want our stents to clot off. I was like, well, can't give him no FFP as I'm replacing blood volume multiple times. So we had a discussion and we decided instead of 1-to-1, we would do 2 red cells to every 1 plasma. And then after cardiology did their stents, vascular surgery came in and did angiography of the leg. And basically he had clot proximal and distal to their attempted cannulation site. So they did endarterectomies and stent placements. It was very complicated because he was still needing a significant amount of anticoagulation because you need to continue the anticoagulation for some period of time for several hours after the stents. So they're bleeding, which didn't help, and it took a very long time. Eventually, we were able to bring our bivalrudin down to normal levels. We gave him Plavix by the OG tube, and then we were able to turn off the cangrelor a few hours later. And by the time we actually got to the ICU, he was starting to dry up. So we transfused 31 red cells, 15 plasma, and 1 platelet in the OR because his platelet count did get to less than 20,000 in like the 10.5-hour take back. Despite that, all that transfusion, again, when we were off the cangrelor and when the bival was at a more normal level, he just dried up. So despite us being far, far away from our standard of care for massive transfusion, he received no transfusion in the ICU that night. And he very, very much looked like somebody who was hypercoagulable, and we were very, very sure that he had HIT. So we did draw a HIT panel initially when we came back to the operating room as we were turning off the heparin and starting the bivalrudin. Don't do that. If you're going to draw a HIT panel, wait until the heparin is out of the system, so maybe 4 hours or so, because the lab called and yelled at us because they had to do a lot of dilutions with his blood to get the testing correct. But his HIT panel actually came back negative. He continued to have hemostasis in the ICU despite being anticoagulated and thrombocytopenic with counts in the low 20s. Hematology said it was okay to put him on heparin, but nobody wanted to actually do that. Hematology thought this was most likely due to integralin, which was the 2B3A inhibitor that he was on prior to his CABG, which is a standard thing. And then some people, integralin can cause thrombocytopenia and thrombosis. Sorry, not thrombocytosis, thrombosis. So Heme said not to evaluate further for hypercoagulability, but the ICU did anyway. He was found to be a heterozygote for factor V Leiden, but unfortunately, factor V Leiden is only venous thrombosis, so that also did not explain his problem. So here's an algorithm for the workup of thrombocytopenia. This is pretty easy to see he does not fit any category other than isolated thrombocytopenia. He didn't have hereditary thrombocytopenia. He had normal peripheral smear. He didn't have any platelet clumping. And so we're kind of led down the road of ITP, drug-induced thrombocytopenia, HIT, DIC. He was definitely not in DIC. So hematology was clinging on to the integralin thing. So a little review of HIT. Results from an autoantibody directed at the PF4 complex with heparin, and the antibody activates the platelet and causes both arterial and venous thrombosis. So HIT1 and HIT2 are the major subtypes. HIT1, you get kind of like a gradual, mild decrease in your platelet count. There's no thrombosis. You can continue the heparin, no problem. Type 2 is when you have the PF4 antibodies that are complex to the heparin and are very likely to get thrombosis. And those are the people that you need to stop the heparin on. There are a few other variants, including delayed onset, refractory, and spontaneous HIT. Delayed onset is thrombocytopenia and thrombosis up to 5 days after the heparin has been discontinued. Refractory is when you continue to have thrombocytopenia and thrombosis for weeks after stopping heparin. And then spontaneous is actually HIT in the absence of recent heparin exposure. Most of these patients have a preceding infection or have undergone some type of major surgical procedure that somehow sets off this cascade. The diagnostic criteria for spontaneous HIT is otherwise unexplained thrombocytopenia and or thrombosis without recent exposure. You have the anti-PF4 antibodies and you have minimal amounts of heparin, something along the order of a heparin flush. Typical presentation of HIT type 2 is onset of thrombocytopenia within 5 to 10 days of starting heparin, bleeding, thrombosis in up to 50% of people, and some type of systemic reaction, like anaphylaxis has been described. So you should have a high index of suspicion for HIT if the platelet count is decreased by 50% or more, you have venous or arterial thrombosis, you have skin necrosis at injection sites, or if you have some type of acute systemic reaction, something mimicking heparin or sepsis or even cardiac arrest after IV heparin. So we kind of had all those except the injection issues at the skin because it was given IV. The HIT panel takes days to come back. So there are multiple scores that you can use to predict whether or not somebody actually has HIT, and you can use those to help direct your therapy. Probably the most common one is the 4 T's score. So if they have intermediate or high probability, you should treat them like they have HIT. And if it is a low probability, then you can continue heparin and treat them like they don't have HIT. So the components of the 4T score are thrombocytopenia, timing of the platelet count fall, thrombosis, and whether or not there are potentially other causes of thrombocytopenia. So a platelet count fall of greater than 50% with a nadir greater than 20,000 is 2 points. So we had that. The timing of the platelet fall count, so if it's between 5 to 10 days, or 1 day if they've had heparin within the past 30 days, then that's 2 points. We did not have that. The platelet fall count between 5 to 10 days of starting heparin or greater than 10 days after starting heparin, or 1 day within heparin, 30 to 100 days within heparin, 1 point, we didn't have that. Or platelet fall less than 4 days without recent exposure, we had that, so 0 points there. Thrombosis, confirmed thrombosis, acute systemic reaction, skin necrosis after IV unfractionated heparin. We did have confirmed thrombosis, and we had a cardiac arrest, which, maybe that was because of the heparin. So we got those 2 points. And then other causes of thrombocytopenia, we didn't feel there were any apparent at that time, so that's 2 more points. So we had a score of 6, which puts us in the high likelihood of HIT, and so treating him as if he had HIT was appropriate. There is something on bypass called high flow excursion, where if you don't have an adequate ACT, platelets can collect on the filter. And we did ask the perfusionists if they had seen anything like this, and they did not. So that took another cause of thrombocytopenia out of the picture. So now we're going to get on to integralin, which is what hematology thought was the etiology of this problem. So it's a 2B3A inhibitor. It's known to cause thrombocytopenia, even though in the trials that were done prior to it being FDA approved, this was not something that was reported a lot. But in the years since it's been out, it's being recognized more and more. In rare circumstances, it can cause a HIT-like reaction with thrombocytopenia and thrombosis. So you get this PF4, I'm going to say integralin because I can't say the generic name. Antibodies have been demonstrated in patients with integralin-induced thrombocytopenia, and the theory is that the platelet fragments activate a clotting cascade in the same fashion as HIT. So there are very, very few case reports of thrombocytopenia and thrombosis associated with integralin in the literature, and they are pretty much all the same. So this first one is a 75-year-old man who had a STEMI. He had the standard aspirin, Plavix, integralin medication for his stent. 2 hours after his cath, his platelet count went from his baseline of 200,000 to 8,000. He was having hypoxemia. They couldn't do a CT scan because he was in renal failure, so they did extremity ultrasounds. He had clots in all 4 extremities. He was HIT negative. They kept him on heparin, and platelet count returned to normal in a week when he was still on heparin. Second case report, 73-year-old man with angina, had PCI with aspirin, heparin, integralin, Plavix. 3 hours after the cath, his platelet count was 78,000, down from 238,000. He had a clinical decline overnight. Lower extremity Dopplers were positive for DVT, and CT scan was positive for PEs. Third case report, 70-year-old man with a STEMI, aspirin, Plavix, heparin, integralin. 5 hours after his PCI, platelet count down to 35,000 from 210,000. Integralin was stopped. 1 hour later, he had a STEMI. They took him back to the cath lab. He had thrombosed his new RCA stent. They did a multiplate ADP platelet function test at the time when he was thrombocytopenic and showed that he actually had very high platelet activity. And then the last case report was a 63-year-old man with coronary disease, had a PCI, aspirin, Plavix, heparin, integralin. 10 hours after his intervention, his platelet count was 94,000, down from his baseline of 302,000. He was also found to have DVTs and a PE. So while there are certainly similarities between this patient and the published case reports of thrombocytopenia and thrombosis associated with integralin, there are also glaring differences. So all of these case reports were within a few hours of starting integralin, and this person was on integralin for days before he had any lab abnormalities. And with the serotonin release assay being negative on the HIT, that pretty much rules out HIT, even though he really looked like he had HIT. Don't think that the thrombocytopenia was related to the bypass run or the circuitry. It continued for over a week after bypass. He was not in DIC. Clinically, he was definitely hypercoagulable. So I don't think we ever really came to a very satisfying conclusion as to what happened to him. And I'd love to hear if any of our basic scientists or other ICU doctors or transfusion people have any idea what this could have been. Sam?
So I was fortunate enough to also get involved in this case. So Dr. Volk and I talked about this at length multiple times. The hypercoagulability was interesting because I think initially we thought, oh, he clotted his leg off too, so this means that he has to have this global hypercoagulability. He had actually had an aortal diaphragm, and the cannulation was very tricky. And so on the left side, the arterial cannulation was a solid place to cannulate. He actually changed the graft. So that was a little bit of a red herring. There was some discussion over whether there was a surgical issue, and that brief episode of hypotension, brief and then became prolonged episode of hypotension in the ICU actually led to that thrombosis. Again, it doesn't explain the thrombocytopenia. We still don't have a great explanation for.
Yeah, and even if it was mechanical, like say he arrested because he got hypotensive and then he clotted his grafts because he had open cardiac massage on his grafts and his left femoral artery thrombosed because of the cannula, it still doesn't explain why we were able to have him not bleed while anticoagulated with a platelet count of 20,000 after having given, 30 plus units of red cells and not enough plasma replacement, right? It just doesn't make any sense.
One of the things that did point a little bit in that direction was the fact that 3 of the 4 grafts down were all vein grafts. So the artery
Yeah.
was still intact, which is typical if you're in direct failure, like the limb does kind of strange.
Yeah. Anybody else have any thoughts? Questions? Yeah, he was on Integralin for 2 days. After the cath, while they were waiting for bypass, because he came in with an NSTEMI, so they wanted to give him a little bit of time. He got collected complications in the ICU, eventually got a fungemia, and the family withdrew care. All right, thanks.